Some problem here. One minute, has some problem.
Dr. Prashant.
Yeah, 1 minute. There's some problem, huh? Between.
Okay, fine.
Yeah.
Sir, your video is
Yeah.
Your video is this.
Yes, yes.
protected.
Just yeah. There's some problem here. I'm unable to. Is it okay now?
No. I think we will continue. Now it is okay. Yes.
Yeah, now it's okay. No? Yeah.
Yeah.
I think it is like this.
Again, this
No,
is not
what
right.
happens? No, what happens when I put it in landscape, the presentation doesn't move forward. So I have to put it.
Okay, no problem. Continue.
Good afternoon, doctors.
Yeah.
On behalf of Hetero Healthcare, I, Dr. Prashant Khandeparkar, welcome you to this webinar on influenza and its prevention. Today we have got eminent doctors, Dr. Sainath Pawar and Dr. Swati Shrotri with us to share their experience on influenza and its prevention. At Hetero Healthcare, doctors, as you know, Hetero Healthcare is an innovative pharmaceutical company. Our journey began in 1993. We have 30 years of experience. We have 300 plus products in market. We have 21,000 employees, and we have state-of-art manufacturing at many centers. We are the largest manufacturers of ARVs, APIs. Hetero Healthcare is a 360-degree solution provider. We strive to fulfill unmet healthcare needs. We reach out to customers across India. We have a wide range of products encompassing multiple specialties, and we are pioneers in quality and innovation. We have a distinction of bringing 4 biosimilar products to market within 5 years of initiation, like darbepoetin, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic, we have introduced 3 antivirals for patient care, which is why we were awarded with Award of Excellence in 2020 for COVID drugs. For today's meeting, we have got Dr. Sainath Pawar and Dr. Swati Shrotri, as I said. Dr. Swati Shrotri is MBBS DCH, MD Pediatrics. Madam is consulting pediatrician and neonatologist since 1996 at Satara. Madam has passed with distinction, fellowship and diploma in child adolescent diseases and child nutrition from Boston University, USA. Dr. Shrotri is director and founder of Chirayu Children's Hospital, Satara. Is life member of IMA, life member Indian Association of Pediatricians, life member National Neonatologist Forum India, and life member Infectious Disease of Pediatrics. Dr. Shrotri has served and arranged many free camps in and around Satara. Has participated in free camps at Lok Bidri Prakalpa, Hemikasa Prakalpa, and Search Prakalpa of Dr. Abhay Bam, graduates of Gadchiroli district. The next speaker is Dr. Sainath Pawar. Sir is fellow at MBBS MD Pediatrics DCH FCPS, fellow in allergy and asthma from University Hospital of Worcester, UK, certified pediatric flexible bronchoscopist by APPS and IAP, consulting pediatrician and pediatric pulmonologist. Dr. Pawar is consulting allergy and asthma specialist, president Kolhapur Academy of Pediatrics 2024, national trainer for NTAP IAP action plan, national trainer for Pulmostar IAP module, national trainer for IAP REAP module, executive board member for Maharashtra Respiratory chapter of IAP. Dr. Sainath Pawar and Dr. Shruti Madam, welcome to this webinar, and I hand over the session to you for further deliberations. Thank you.
I'll share.
Yes.
Just stop the sharing.
Yeah.
So, good evening, all doctors. And first of all, I would like to thanks, sir, for giving me this opportunity. And so, myself is Dr. Sainath Pawar, and today's topic is empiric use of oseltamivir in flu management. So, let us discuss few things, and then my madam will add her experience in the this presentation. So today's contents are like healthcare challenges in monsoon and their diagnosis, influenza flu and its complications, clinical evidence of oseltamivir, and guidelines recommendation for empiric use of oseltamivir. So what are the key facts? Actually, there are around there are around a billion cases of seasonal influenza annually, including 3 to 5 million cases of severe illness uh, total. So severe illness and seasonal influenza. So this causes around 2,90,000 to 6,50,000 respiratory deaths annually. 99% of death in children are under 5 years of age with influenza-related lower respiratory tract infection, and these are mainly in the developing countries. The symptoms begin 1 to 4 after infection and usually last for around a week. So, what are the healthcare-related challenges in monsoon? So this is a influenza. First is influenza-like illness. Second is H1N1. Third is severe acute respiratory illness, and fourth is COVID-19. So there was a study which has done in Chennai, Tamil Nadu. They have done this study for around a year of 7 years, and the study was done by Department of Virology in 2019, and it was done in King Institute of Preventive Medicine and Research. And almost 36,670 specimens were subjected to influenza analysis. And the total duration of the study was around 7 years. And what they could found is influenza positivity started with the onset of monsoon and peaks during the post-monsoon months. And this graph we can see here, these are the cases of the influenza infection, and these are the deaths. This blue one is showing 2015 cases. These are 4,259. This red one are 2018, that is 15,266. And green one is 2019, which was 28,000. So 4,000, 15,000, and 28,000. This was the 15, 18, 19. And the death also similarly in 15, 299, in 18, 11, 28, and in 2019 it was 12, 18. So as you are seeing here that as the time is going on, the years are going on, the number of cases of influenza and related death both are increasing. So this is a very important thing for us, and we are also seeing this in our practice that number of influenza or viral infections are much more than, and they are now unpredictable. Like previously, there used to be some specific season, but now also we are seeing that post monsoon we are getting good number of viral infections. So incidence of influenza and related deaths increasing alarmingly in India. So let's go to the what are the basic symptoms of flu. So as everybody knows that these are fever with chills, body aches, cough, running nose, maybe stuffy nose, congestion, sometimes headache, sore throat, feeling of tiredness. There is a feeling of rundown, diarrhea, vomiting may be associated in some more in the kids. So let us discuss with few cases actually. So this is a 2 years old female child admitted with cough 5 days, dry cough, cold 4 days, fever 3 days, high grade intermittent. Then on when we have examined the child, the heart rate was 125, respiratory rate of 35. There was tachypnea, and the RS shows bilateral occasional clefts and bronchi. And the provisional diagnosis of this patient was LRTI. So we are treating this patient as LRTI. We have done a basic investigation like CBC, HB of 11, WBC count of 11,500. This polymorph 26, lymphocyte 72, which is showing a slight lymphocytosis, and eosine and monocytes are 2%. Platelets are 2.46, that is normal. CRP is borderly raised, but that is 9. We can take it as normal. Here we can see the X-ray, which is showing a hilar prominence. Here is the and right middle lobe patch you can see here. So as a routine patient like LRTI, we have started him on an IV antibiotic. We have started him on a bronchodilator nebulizations because of the wheezing and bronchi. And slowly the little tachypnea was reduced. Patient was feeling as if he's getting little better. But on day 3 of admission, this again getting better patient again become drowsy and he becomes sick looking child. Child was not accepting food. Everything was not going well. So somehow we was thinking we have started the child on antibiotic. We have given him nebulization. He was improving. Then why is not again? Why has become drowsy and all those things? So we had thought of H1N1 and we have sent the swab. So which came positive. So as soon as we have sent the swab, we have started him on oseltamivir. After starting oseltamivir within next 48 hours, patient also has shown good improvement and his sensorium improved and tachypnea and fever also subsided. So this was our first case. So let us, this after first case, we'll discuss few things. That is, whenever we are seeing patient in OPD, then generally we are seeing two types of patient, viral and bacterial. So here is the guidance. Guidance is that how we should means divide the viral and bacterial, how we should differentiate. So whenever there is a viral, there is an acute onset, more gradual than bacterial. The family history of similar. Somebody has got cough cold, similar cough cold fever in family, so we can take it as this is more likely to be viral. Bacterial generally it starts with high grade fever. There is no other, may not be other family member affected. Cough is the predominant symptom in viral infections and bacterial infection. Very frequently, the cough will be absent. Cervical lymphadenopathy more in the bacterial infection. Associated symptoms like rhinorrhea, exanthema, hoarseness of voice, diarrhea, conjunctivitis, that is multi-system affection seen in the viral infection. Bacterial infections are more localized, more specified infections. So there is a less likely all these symptoms will be there. Second thing, when you are examining the throat, there may be mild redness of the pharynx and this pharyngeal mucosa, but if in bacterial journal, you will see the thick exudate, purulent patchy tonsils, or there will be purulent throat you can see. So that is going in more of favor of bacterial. So now we are coming to case number 2. So this is the first child was 2 years old, which was a smaller child. Now this is a older child who is a 14 years old boy with no underlying specific comorbid conditions, and he was referred to tertiary care center for the complaints of, he had complaint of low grade fever, sore throat, myalgia, sore throat for almost last 7 days. There was not significant breathlessness, vomiting, diarrhea, but he has received antibiotics in the form of ceftriaxone and piperacillin, but the fever was persisting, the cough was persisting. So patient wanted to shift to the higher center, so they have referred the patient to us. So this was, you can say that uh, there was X-ray was showing a pneumonia. So we can say this is a case of walking pneumonia. Means patient is relatively stable, but he has got pneumonia. So his vital were like pulse of 110 per minute, BP of 110 by 72 per minute, temperature of 100 degrees Fahrenheit. There was on examination of respiratory system, there was a bronchial breathing, bilateral chords, crackles in inframammillary area, the mid-zone interstitial inflates on the chest radiograph. The nasopharyngeal swab was taken. The PCR of that nasopharyngeal swab, which has shown the H1N1 positive. So basically, he was having X-ray was showing patch, and H1N1 was sent because he has already received antibiotics, still not getting better. He has referred to tertiary center. So we had done a H1N1 swab, which was a positive actually. CRP was just above normal, that was 10. So basically, rest CBS, abdominal, CNS system were normal. Laboratory was, hemogram was normal. Liver function tests were also normal. So this was a case of viral diarrhea, which was H1N1, viral pneumonia, which was H1N1 pneumonia. Patient were relatively stable. So this is a walking pneumonia, we can say, and the best drug is oseltamivir. So this is the X-ray. We can see that there is a bilateral infiltrates are seen. So treatment, obviously, we have started him on oseltamivir as he was an adult, like 14 years old child, like adult only, for above 50 kg weight. So we have started him on 75 milligram BID for 5 days with paracetamol, oral hydration, hand wash was explained, and then slowly patient showed a good improvement. The X-ray which was done after few days was here. It is a good, showing a good improvement actually. So oseltamivir has worked wonderfully in this patient. So now let us discuss with some theory, that is influenza virus. So influenza, one of the most common infectious disease which we have seen in our OPD also, and which is caused by influenza virus. It is a highly contagious airborne disease that occurs in seasonal epidemic, and it manifests as an acute febrile illness. It can cause sometimes mild illness, sometimes severe illness. So sometimes it can cause a serious infection, sometimes it can lead to death, which should not be actually occurring. And here we are seeing this diagram. So here, this is a structure of influenza virus, which is actually there are two surface proteins on which the differentiation, or we can classification of the influenza virus is done. Influenza A virus mainly. So this is a hemagglutinin and neuraminidase surface protein. So depending on their mutation, their nomenclature changes like H1N1, H2N2, H3N2, and all those things. So now, which are the currently circulating subtypes? H1N1 and H3N2. So what are the types of influenza virus? First, as we had discussed, it is influenza A virus, which causes frequent epidemic due to the minor antigenic variations, and every time, sorry, every time there is a mutation, there is antigenic variation. So whatever patient has got the immunity last infection, already there is a mutation and antigenic variation. So again, next epidemic, sometimes they can cause pandemics also due to the major antigenic variation. So influenza B virus, they infect humans and cause local epidemics. Influenza C virus can infect humans and swines. Generally, they are mild diseases. So this is the classification of overall influenza A virus, and A virus, sorry, influenza virus A is divided depending on H and N. So, sorry. So transmission of the flu virus. So as we know that flu can spread to others by basically uh, airborne this spread by droplets spread, and generally it can cross the 6 feet away distance. So mainly, it is spread by droplet made when patient coughs, sneeze, or talk, and anybody who is in within next 6 feet, they can catch the infection. So people should stay away. So whenever there is somebody has got flu, he should stay away from the other people. If the child is having flu, so better to stay at home. Do not go to the school, because otherwise he will give that flu to the many other students. So always, whenever there is a fever and viral like things, better to stay at home. Don't allow the children to come at school. So most healthy adult may be able to infect the other people. They start from the 1 day before symptoms and 5 to 7 days after becoming sick. So, and children can transmit this virus more than 7 days also. So children are transmitting more. They are transmitting it for longer time actually. Okay, so now let us differentiate between influenza-like illness, H1N1, severe acute respiratory illness, and COVID-19. So fever, myalgia, cough, you can say like lack of energy means weakness, we can say, and sore throat will be there in all of these. But breathlessness, generally influenza-like illness will not have. Less other thing, H1N1, SARI, and COVID-19 may have. There will be loss and smell and taste classically in COVID-19. Diarrhea may be there in COVID-19. Sometimes it may be associated with flu. Headache may or may not be there. Means not very sure, but every all symptoms can, all four can have headache. So whenever we are talking about emergency warning signs of influenza virus, influenza illness, we can say. So whenever a child is having fast breathing or trouble breathing, means basically tachypnea, we can say respiratory distress, we can say, Bluish skin color means cyanosis, we can say. Not drinking enough fluid, not waking up means the child is drowsy, the sensorium is not good. Being so irritable that the child is not continuously irritable, uncomfortable, child is crying continuously, doesn't want to take by anybody. So these are the symptoms that we should be alert. And if the child has flu-like symptoms, he improves, and again biphasic fever is coming. Again, that time we should be more vigilant on this patient. And if the patient has got rash, then we should think that anything is going to be wrong with this patient. So, in addition to above, means these are the signs in children. But if the child is infant, then mainly we should concentrate on his feeding pattern. Means if not able to feed, he is not able to, he is tachypnic breathing. So that is a very, very dangerous thing. He sometimes he get dehydrated and he is not able to produce tears, and his urine output will reduce. So these, if the infant is there, we have to keep these things more cautiously. So what are the complications of flu, like pneumonia, bronchitis, ear infection, worsening of existing diseases? If the child has got asthma, COPD, child will not have COPD. If the child has got asthma, and adults who has got COPD, asthma or COPD, if they can get viral infection, the normal child will, maybe normal adult will improve in 5 to 7 days, but this asthma COPD patient will aggravate their asthma and they will have this prolonged illness. So ARDS, sometimes ARDS is the nightmare for the intensivist. So be prepared for ARDS. And as we have discussed, death is also possible. We should not get it, but it is possible. So who is at higher risk? Means every population, all population is at higher risk, but there are some categories that we should look more cautiously in those patients. So first thing is like those, as we have discussed, asthma, allergy, they are already, their allergy and asthma part will be triggered by this viral and they will have prolonged illness. Second thing is any chronic kidney, liver, neurological disease, juvenile diabetes patient, they have low immunity, so they can have more problem. Any immunocompromised status, maybe because of the drugs, maybe because of the HIV, cancer, immunosuppressive medication, they will have more problems with this viral infection. Sickle cell disease can have more infection, more problems. Obesity, and those who are long-term care facility, they are living in long-term care facility, they will have more problems. So what is the management? So as we know that always supportive management is very important. Bed rest, increased fluid intake, cough suppressant if required. Generally we do not give, but in some cases we can give if there is a dry cough. Antibiotic like paracetamol is used. NSAID sometimes if there is a pain, or it's better to avoid those drugs. Uh, Most patients with influenza will recover within 3 to 5 days, but the weakness will persist for few days. We can say that few weeks. The severe cases may require IV sometimes, and sometimes they will require admission and other supportive measures also. So antiviral drug. So now we are coming to antiviral drugs. So there are two major antiviral groups. One is neuraminidase inhibitors, and second is the adamantins, that is M2 ion channel blockers. So neuraminidase inhibitors, they will basically block the viral neuraminidase enzyme, which is critical in releasing virions from the infected host cell. So as the host cell will not able to generate that virion, the viral replication will stop, and that patient, the number of virus will be reduced. So which are those drugs? Oseltamivir and zanamivir. And this M2 ion channel blockers are amantadine and rimantadine. Generally, they will interfere with hydrogen ion channel activity of the influenza A virus, and they will block their entry into the host cells. Here, virions are not produced, and here entry is restricted. So which is the common drug we are using? Definitely, we are using only oseltamivir. So let's discuss about the oseltamivir also. So basically, oseltamivir is a potent and selective inhibitor of the neuraminidase enzyme of the influenza virus A and B. It is actually a prodrug, and when it converted to active form, which is called as oseltamivir carboxylase, which is converted into liver. So it inhibits influenza viral replication, as we have discussed. It prevents further spread of the infection, and it is effective against A and B and all the strains like H5N1, H1N1, and H9N2. So here we are seeing that this is a normal release of virions, but These are the neuraminidase inhibitors. They will act on the host cell. They will block the uh, virion sites, and there will be no virion release. So the number of viruses will be reduced. So it was the first oral neuraminidase inhibitors, and it is approved in more than 100 countries for the use in children. So FDA, CDC, American Academy of Pediatrics, all this approves use of oseltamivir in children. So let us come to dose now. So basically there are two things. Like one is treatment. Patient has got influenza and we are going to treat it. And second thing is chemoprophylaxis. There is some contact or something is there, epidemic or something, that we need to give a chemoprophylaxis to the patient. So let's first discuss with the treatment part. So basically, adult will give 75 milligram capsule is there. So twice daily, that is a simple dose for 5 days treatment. Children, depending on weight. So first is less than 15 kg. So it is 60 milligram per day, twice daily. Divided into, म्हणजे 30 milligram BD. In 15 to 23, it is 90 milligram per day, that is 45 milligram BD. Uh, it is 23 to 40, it is 120 milligram per day, that is 60 milligram PD. And in more than 40, adult dose 75 milligram PD. So, so there is a chemoprophylaxis now we are coming to. Basically, generally it is a means we are giving BD dose. So that is one dose OD, means half dose, we can say total, whatever total dose we are calculating. Half dose OD is the chemoprophylaxis. Adult 75 milligram OD, 50 less than 50 kg, 30 milligram, 15 to 23, 45, 23 to 40, 60, and more than 40 is 75 milligram. So these are OD doses. Chemoprophylaxis, it is generally given for 10 days. And whenever there is a community outbreak, seasonal or pre-exposure, we can give this for prophylaxis can be given up to 6 weeks. And sometimes in immunocompromised patient, we can give it for 12 weeks also. And there is a 30 milligram capsule of hetero is available. Those children who are able to take oral capsule, they can take this capsule also. So, and always remember that if you are thinking of influenza and if you want to start oseltamivir, start it as early as possible, best within 48 hours of symptom. So that is first thing. But by chance, sometimes patient may come to you later, means after 48 hours. Means, so it is no harm in starting this drug after 48 hours. The best is within 48 hours. But if you started after 48 hours, also it will give benefit to that patient. So benefits of empiric or early use of oseltamivir. So, oseltamivir treatment of influenza illness reduce the lower respiratory tract complications, antibiotic use, and hospitalization. So, there was a study which has done and which has studied 3,564 subjects from age range was around 13 to almost adult. And these patients had influenza-like illnesses and they have done the study. So they have seen that in patient with influenza, oseltamivir treatment reduces. First is antibiotic use by 26 by 7%. Second, influenza-related lower respiratory tract complications resulting will be less because of the uh, by 55% and hospitalization by around 60% or 59%. So reducing occurrence and severity of pneumonia due to H1N1 by early oseltamivir administration. So there was a study done on 442 patients. So the median time of symptom starting to oseltamivir was 5 days. So they have divided into 4 groups, like less than 2 days starting of oseltamivir, 3 to 7, 8 to 14, and more than 14 days. So what they have seen that both the probability of any severity of pneumonia and the probability of severe pneumonia increases gradually with the time of onset, means time of symptoms and oseltamivir admission. So as you administer oseltamivir late, the chances of pneumonia and severe pneumonia are more. Earlier initiation, less hospitalization, shorten hospitalization, less severity. Uh, but even if, as we already discussed, even it administered after 48 hours, it has shown the considerable potential for decreasing the complication or pneumonia. So patient with shortened time to oseltamivir admission were discharged earlier from the hospital. So this was the shown data. So now there is two another thing that we are seeing, that oseltamivir, if combined with azithromycin. So basically, what was the logic, that ki oseltamivir is viral infection and sometimes they may get superadded infection, secondary bacterial infection. So whether this azithromycin will help. So basically, they have done this study, and what they have seen here, that oseltamivir azithromycin combination therapy reduce the secondary bacterial infection. You can see the incidence of secondary bacterial infection. It was much more in oseltamivir group than the combination group. Here also we can see that those patients who were required respiratory support was more in only oseltamivir group than the azithromycin group. So basically, what is the conclusion, that oseltamivir and azithromycin combined treatment offers significant reduction in incidence of secondary bacterial infection and required less respiratory supports. So this combined treatment offers significant and it has reduced the influenza symptom severity score also. So it is recommended. Okay. So what is the WHO recommendation? Empiric treatment is strongly recommended when you are strongly suspecting the this influenza infection. Treatment should be started as early as possible. Laboratory confirmation of the influenza virus can be done, but if it is not possible, you can start the treatment. It is not necessary that you should do a this throat swab for H1N1. So if you are starting oseltamivir without sending swab also, in some situation it is accepted. Negative laboratory test, maybe negative laboratory test means you have sent the H1N1, but test is negative. But if you are strongly suspecting the H1N1 and test is negative, please you give your treatment, so that patient should get benefit of doubt, because sometimes because of there are fallacies in lab report also, means sometimes we are not collecting it properly, sometimes it is not sent properly, it is not done in time. There are many things that will affect the result of that report. So if the higher risk individual has been exposed to the patient with influenza, we can consider the prophylactic presumptive treatment with oseltamivir also. So empiric supportive therapy and monitoring, give empirical antimicrobials to treat all pathogenic causing SARI. Empiric antibiotic treatment based on your clinical judgment, your area antibiotic use and all those things. So whether it is a community acquired setting or there is a community acquired and healthcare setting. So depending on that, we can decide the choice of antibiotic. So empirical therapy includes the treatment with oseltamivir when there is a local circulation of other risk factors, including travel history or exposure to the animal influenza virus. So whenever there is epidemic, travel history or something, you can use this oseltamivir. So what is the overall summary? The proper diagnosis and early treatment can prevent the flu complications. Empiric use of oseltamivir reduce the lower respiratory tract complication, hospitalization, and antibiotic use. WHO, American Thoracic Society, recommend the empiric use of oseltamivir. So this is yeah. I would like to ask Madam, so whether Madam would like to add anything or any insights about her patients in this influenza like cases. Madam, mute.
One thing I would like to ask you ki how suppose if we are giving antiviral treatment oseltamivir on OPD basis,
Yeah,
means in the first visit we will never use it.
yeah.
Subsequently, if the patient is not improving with antibacterial, then we can, or there is positive history of viral infection in family, then if we start oseltamivir, and if patient worsens irrespective of our suspicion of viral infection, how to proceed?
The first thing that this patient, if he's after starting oseltamivir, he is deteriorating. So either he is going to into some complications, or it may be some other infection, maybe severe bacterial infection. So basically, first thing we have to admit this patient, we have to investigate this patient for all the investigations which are required, like whether it is going towards bacterial. Now we are suspected viral, not confirmed. So
Yes.
after that, whether it is a bacterial infection, whether child is going into like complications like ARDS or something like that,
Sari
or he
also.
is having, yeah, or sorry, ARDS and all those things, or either we are dealing with something else only. So we have to think, and first thing we have to admit this patient, we have to observe, and then we have to decide everything. I think
Yes.
my opinion is OPD basis we can start on oseltamivir. That is not a problem. But if the patient is not improving, definitely we have to see
Look
for
for
whether,
other.
yeah, other things we have to see for.
And one more
Sometimes,
thing I would like to ask about viral pneumonia, like in adults or in children also. Is there any sequelae post viral lung assault like
yeah, yeah. It
fibrosis
depends
or
on actually. Again, depends whether if it is a clear-cut viral infection and he is improving after treatment, they are less likely that he will have long-term any comorbidities. But
hmm,
only thing that if he has got into ARDS or something, he has required ventilation, then VAC or something, then he may have some comorbidities. Otherwise, as a clear-cut flu infection, we don't expect any
will not.
longer comorbidities. Any complications can, depending on the situation, we have to observe the patient.
I
As a
think
routine
lung.
flu, yeah,
I
yeah, yes,
think
ma'am.
sequelae is more common with COVID,
Yeah, yeah,
as per our
yeah,
experience.
yeah, yes, yes, yes. Flu influenza is
Hmm.
when it is a OPD basis or IPD basis, treated regular basis, it will not cause any problem per se long term. Yes, sir.
Yes.
COVID-19 can cause anything now. That is okay.
Hmm. Yes. Nice
Yes,
presentation.
yes. Thank you, madam.
Thank you.
Thank you.
Thanks, doctor. It was a nice presentation.
Sir,
What I
do you
want to
want to
ask
add
is,
anything, sir?
yeah, I want to ask one thing. In which patient group will oseltamivir work the best?
In which patient group?
You mean to
Means
say age group, sir?
Age group.
generally, age group means all children can get, but infants generally they are tricky. As we had already discussed, there is a more risk of complications in infants.
Correct,
So that is one thing. And our one of the slide that those who are higher risk, like asthma, allergy,
correct.
chronic diseases, those we have to start it early, or they will means if there this viral infection we control early, that
Hmm.
will be more beneficial. See, normal patient will have viral infection in 3 to 5 days, he will get better. But these patients are going to get more problems. So we should start this medicine in them. They are on priority list.
So that they prevent, we prevent
Yeah.
them going into complications.
Complications also. Complications also.
Yes, yes, yes.
And sir, do you
Well,
want to add anything in this?
no. It was a lovely presentation, and we got good insights. Thanks, madam, also for this, contribution, and we got good insights into this.
Thank you.
Yeah,
Thank you, sir. Thank you.
yeah. And any major side effects you have seen with oseltamivir?
No.
Nothing much. Side
Nothing
effect
much.
access. Nausea, vomiting, or sometimes.
Yeah,
That's
that
all.
is, yeah. So thanks, doctor, for this presentation. Thank
Yes,
all the
yes.
participating doctors for taking out time and attending this. Thank
Yes.
you, marketing team Hitro, for this conceptualization and implementing this webinar. Thanks, IT team, for your support, and thank you, field personnel of Hitro, for super coordination. Thanks all of you once again. Thank you, and I'm signing off.
Thank you.
Thank you.
Yes. Thank you.
Thank you.
Thank
Wish you a
you.
Thank
very
you.
good evening. Thank you.
Yes. Thank you.
Thanks, Girdhar.